Barinder, do you want to add
Yeah,
more to that?
we definitely see that on the ground as well, where all of these different clinicians and these different teams, they do have very, very different workflows because as you get just increasing sophistication, which is natural, right? Medicine is evolving at a rapid pace. People are going to develop new ways of doing old things, and also they're going to discover new diseases and new drugs that they need to implement, new technologies. It's very, very difficult to find just one thing that meets all those needs and does them in a way that really empowers users to provide the best patient care. And really, it's difficult on the operational side of things as well if you have this one tool, because how do you get buy-in, and especially the type of buy-in that you need to really implement something efficiently and effectively, and have users not develop like some of these weird workarounds that are poorly documented? Because what you see is a lot of people think if I get this one solution, it'll make things operationally more, just much more simpler. But really, what it kind of does is it gives you a different type of complexity where now you have all these like these scattered workflows and all of these workarounds that you're not really aware of and you're not able to sort of manage and keep track of. And also the costs become hidden as well. If you have these workarounds and these poorly functioning systems that aren't really optimized, you get this effect on patient care that doesn't really that's really difficult to capture. Like one of the great examples I think about when I think about this problem is there's a surgeon in the OR that I saw who didn't have access to a really, really good enterprise viewer. And so what he did was he would take screenshots of the CT scan slices that are of interest, paste them in a Word document, and pull those up. And it's like
Oh,
which cases ended up having worse patient outcomes because he didn't have access to high quality imaging. You don't know
oh
because that doesn't
gosh.
show up in reports, right? And so the
Yeah.
costs end up becoming really hidden.
Wow, that's crazy.
Yeah.
Now, no, Barinder, let's talk a little bit more about interoperability. And the industry talks a lot about it, but many healthcare organizations are still operating with a really fragmented imaging environment. Why is interoperability so difficult?
I think Terry actually touched upon it really well early on when she talked about the fact that they have these really old legacy technology, like these legacy systems in place, but they're mixed in with these new systems. And it's the new systems that have made really good use of these standards for interoperability, like FHIR, like DICOM Web. And the fit between these newer, more modern systems and these legacy systems is kind of a wonky fit. They're very ill-fitting systems, and so every additional system that you add, it's a source of friction. And really, when we talk about friction, it's all of these little things that add up. Like extra step here in the workflow, an extra application that you have to navigate to, an extra alert that you have to deal with. And all these things just add up, and it's a cumulative effect, this friction that slows things down, it grinds morale down. And those are the real sort of contributors to poor interoperability, because it's not just a capability issue. It's not just the fact that I've adopted the standard and therefore I'm interoperable. Interoperability without usability is frankly useless, right? You need to be able to have something that's interoperable, not just in the way that it speaks, but also interoperable in that it fits into these flexible, ever evolving workflows.